So good afternoon, good afternoon. I think you guys will remember Daniel from this morning. He's going to give us another talk on student assessment and some psychomotor skills. So welcome back to the podium.
Thank you very much. I hope you all had a good lunch and your bellies are full and that you're not feeling too sleepy. The after lunch spot is always a little tough. So, what I would like to talk to you about today is another talk on assessment. You've seen a lot of talks on assessment, and so hopefully I can add a little bit of a different flavor to that. What I would like to do with you is share examples of my assessment tools that I've developed in the realm of using patient models for people who have amputations or orthotic needs. How many of you use patient models in your curriculum when teaching your students? Okay. So that's probably almost all of you. As a clinician, I love to use patient models. I go into that zone where I know exactly what I'm doing, and I have this paradigm where I show students what to do, and then I bring in patient models and observe them as they do what I did. But let me tell you a little bit of the backstory about how I got interested in this topic of assessing students, because I found I loved patient models, but I didn't really know how to grade or assess students as they were seeing their patient models. You can almost see it's a little dark, but I started working at the University of Washington in 2003, a lot less gray, and maybe a little better looking. Back there on the picture on the right, there's me holding up the wall. And I really felt like using patient models was a fundamental component of teaching. But my mentor, who was co-teaching with me at the time, told me that it's not part of the student's grade. And that sort of bothered me. We spent probably 3/4 of our time in transtibial prosthetics working with patient models. And the other quarter was in lecture, but that's where all of their feedback and the assessment took place. So, being the annoying kid that I am, I was asking the question, well, grade? Why can't we grade this? And I was told, well, it's pretty hard to score these patient interactions. Of course, the kid, why is it too hard? I was told that, really defining the complexity of the task is very challenging. What are you asking students to do? And then, one clinician's idea of successful patient care might be different from another clinician's idea. So there was not a lot of objectivity that we felt wouldn't be brought into this task of assessing students. And then, it takes a lot of time to assess students. So, also being somewhat of a nerd, I decided that I would start writing assessment measures. So what I wanted to do is share some of those assessment measures with you. But first, I just want to tell you what I'm going to tell you at the end, which is my take-home message in case you just happen to go to sleep on it in the first 10 minutes. So, the question is formal assessment of student learning with patient models both possible and worth the effort, because it is a lot of effort. And my answer is yes. I really think it is. Students learn faster when you give them good feedback, which comes out of the assessment, and they learn more. And I have no data to support that. So, as you start to plan your assessment strategies and start to write an assessment measure for your students as they work with patient models, I suggest that you sort of work backwards. This is how I like to do it. I start with the question of what should the student know when they're done with treating their patients? And we've heard that already. I like to sometimes pull out the jargon, but we would call this our goals and objectives. And then think about how are students going to receive this feedback from the assessment measure. Are you going to give them a piece of paper, or are you going to talk to them about it? Are you going to assign some sort of formal score? Because that will guide how you choose to develop your assessment measure. Then the number of opportunities for assessment. So I like to assess students frequently as they're seeing patients. I don't like to wait until the end to give them all of their feedback, because then it can be hard to go back and change things. You know, we don't have a lot of opportunities with our students to see them with patient models, so I find that frequent feedback is very important, but it changes how you construct your measure. It maybe is defined by the task that they're doing at the time rather than the whole project. And I think of a whole project as one of making a prosthesis, whereas the task is maybe, for me, I split down into the first visit of the assessment and casting. The other thing when you're assessing students, because they're very used to taking tests all the time, we all have taken multiple choice tests, we maybe taken essay tests and short answer tests, but when they enter prosthetics and orthotics and they're doing a lot of psychomotor tasks, learning with their hands, they're not used to being assessed in this situation. And our goal of assessment is to help them learn faster and to learn more. And you want those patient interactions not to feel like a test. But you can very quickly make it feel like a test if you have a long checklist of things and you're scoring somebody at the time. So think about how you're going to create a healthy learning environment so that people, that both your patient models feel comfortable, you feel comfortable that you're not hounding over somebody assessing them, and that it's not an exam sort of environment, but that your students feel like they can ask you questions and can learn at the same time as that you're providing them with feedback. And then, as you start to create your assessment measure, the last point is think about what you're going to do when your students don't meet the thresholds that you have set, because it will definitely happen. And sort of the paradigm that I think about when I'm training clinicians is it percentage-based or competency-based? And I think sometimes we throw those words out, but we don't really talk about exactly what they mean. So for me, when I look at, well, if I add all of your project scores up, so say you're terrible at taking an impression, but you're very good at dynamic alignment with a prosthesis, should you pass? I don't know the answer to that. I mean, I think really, say you got 100% on dynamic alignment, we're scoring about dynamic alignment, it's 0, and you end up with a 50, and that's my threshold. Does that add up to a good clinician? I would argue that the answer would be no. That you really need to be able to do everything very well, so that when you start creating an assessment measure, do you really want to sum all of the scores together to create a grade for somebody? Or would you rather think about something as competency-based? So I've moved my assessment of students to competency-based, saying that you have to be competent in every one of these areas before you can graduate. Now, that's a huge burden, because when students do not pass, it becomes a real issue, because not everybody is good at everything. But it really focuses your assessment on what you have to be good at to be considered competent. And some of the examples that I'll show you, I'll point out where I started with the percentage base and how I've shifted away from that. So let's move on to some of the examples. This is one of our faithful volunteers with our students in the hallway. So I use a suite of assessment tools that I've designed to give students feedback. There's the instructor assessment of the student, the one that I do and my colleagues do when they come in to help students during their patient projects. The other one is the student self-assessment. I'm not going to share that form with you because it is exactly the same as the instructor assessment. They're identical. So the students assess themselves on the same measure. And then I will share briefly with you the patient model assessments of students. So the patient model assesses the student's performance also. We talk about setting goals a lot. I'm going to take you through the process of development that I went through with this measure, just so that I can share with you some of the words that I used. I think sometimes it's nice to go into a little bit of depth. So when I'm assessing students when they work with patients, these are the goals that I've set, and I use those goals then to build my assessment measure. So demonstrate professionalism, something that is sort of ambiguous. How do you define that? And that becomes the task of writing a good assessment measure, that you actually have to define what professionalism is, what safe patient care is, deeper, more complex things like interpreting the information from the evaluation and that you gathered during that patient visit. We also, more psychomotor-based skills like demonstrate proficiency in taking a cast, completing your measurements, documenting your patient care. So let's move into the example. Let's take this goal. So I start with these goals as I'm moving towards writing the assessment measure. Demonstrate proficiency in transtibular impression and measurement techniques. Fancy words for being good at taking a cast. So you can then break down that large goal into smaller objectives. This is one of the objectives, which I've written as the student will locate and identify anatomical references for critical measurements. And that becomes then an assessable point that you can assess whether or not the student was able to do that. So if I show you my assessment form here, I know I shouldn't apologize, but what I'm going to tell you now is if you can't see that, the great thing is I'm going to share these forms with you. You can have them. So I will just sort of point out the anatomy of this form, hopefully, with this laser pointer. I know there's a laser here. I can see it. I just have to press the right button. Maybe not. It's that one. Oh, you have to turn it on first. Great. It's good, those little details. So here, it's section 3 of the assessment form, that the students are given well in advance of seeing their patient models for the first time. So they use this assessment form like a rubric and say, oh, this is what Danny's asking me to do with my patients, and this is how I will be scored. So they get the assessment form, they get a whole 5-page set of instructions that explain what I mean by each one of these areas, and then they come with the form and assess themselves. So they will check that off after they've assessed themselves, and then when I give them feedback and write comments, then I will check that off. Part of this was compliance with my co-workers to make sure that they completed the form. So clear identification of landmarks. As an example, I've tried to make this a point that I've broken down a little bit more. So these are the landmarks that I think are important when you're taking a cast of somebody with a transtibial amputation, so the tibia, the fibular head. Trying to make things very objective. And then I have 3 categories. This used to say unacceptable, and it was sort of a, well, it's not a great word to give feedback to students. It doesn't really create that positive learning atmosphere. So I changed it to needs improvement, and then there's acceptable, and then there's excellent. And then I tried to define what each one of these categories are. So landmarks are missing or incorrectly identified is needs improvement. Acceptable, all the landmarks are present. There's slight errors in marking location. And excellent is all present, clearly and accurately located. So with that sort of description, I find that my students learn much more quickly. They say, oh, I just need to do exactly what I was told to do in this process. I can look at the form, I can unbundle this incredibly complex task of seeing a patient, which is not just about taking an impression, but trying to be professional, trying to make sure that you know how to dip the plaster in the water, trying to cut with scissors. You're doing all these different tasks at once, but for the learner, if you can clearly articulate what they're supposed to be doing, and you can give them an example of what's not so good and what is so good, then they know what they're striving for, and it makes it so much easier. So here's another example. This is the goal was to demonstrate proficiency in transtibial impression and measurement techniques. The student will mold plaster to define load-bearing areas on the residual limb and to relieve pressure-intolerant areas through accurate hand placement. Probably in every single PowerPoint that you have about taking an impression or the words that come out of your mouth are probably pretty similar to that. But sometimes the students really have a hard time understanding what that means. So now it gets a little wordy, because I think you have to be wordy to explain, to explain what needs improvement and what is acceptable. I left off excellent because I think you get the tone when you start to read through these, but let's just look at what needs improvement means. What is taking a bad cast? Well, a bad cast, for me, and telling the student, is that the impression doesn't capture the patient's residual limb shape or volume. The knee joint might not be in the right position, and the weight-bearing areas might not be adequately molded. In an acceptable cast, maybe you've changed that and there's some small errors in hand placement, but you still know where the critical landmarks are, they're easily identifiable. Maybe there's small discrepancies in the ml difference between your patient and the cast. But the errors in impression will be correctable in the positive mold. So bad cast, the one that goes in the garbage, is one where your measurements are so far from the patient that you have to throw it away. The acceptable cast, you can correct it. The excellent one is, well, one that doesn't have any of these problems. So once you sort of write needs improvement and acceptable, it becomes much easier to write what excellent is, and the students sort of get the flow of that. So one other thing that I wanted to point out here is, this was before I made it competency-based, where I said that everybody needs to be acceptable in every area. I started assigning weighting, and it was a nightmare because some things I weighted more heavily that were more important, and some things I didn't. So this has been an evolution, and I'm still not there yet. Because this form that I have, the problem that I have is it's too long. And if you can help me with that, please do, because I haven't figured out what to cut out yet, and I think that's one of the real complex things about teaching. So here is something that we all need to do as clinicians. We evaluate our patients, and then we need to interpret that information and decide how we're going to use it to guide our treatment choices. So here's the overarching goal that we talked about earlier. Here's the objective, one of the many objectives that falls under this area of interpreting the information from the evaluation. And it's really the student will describe how the information that they obtain will impact the prosthetic plan of care. Here's this big, long section of the assessment form. So let's just grab one of these topics, and I'll show you how I chose to articulate that. Manual muscle and range of motion. This form that they've got in front of them just has a little line here that says the sound and involved side muscle grades, range of motion limitations, knee integrity. It sort of reminds them, okay, these are the things that you should hit. And then if they wanted to, in advance, refer to the instructions, they could see what needs improvement is. And you look at that and you're like, that's a lot to read. So let's not read this. Let's talk about measurements. I can tell you that one of the things that annoys me the most when I'm trying to teach my students and they've got patient models in front of them is they are working with partners. So we have 2 people and 1 patient model, and one of them does part of the assessment and the other one watches. And then they trade off, which makes sense from a time perspective, but doesn't really teach them what they need to learn. So needs improvement in here, somewhere it should say, don't use your partner's measurements. That's not good, that's not acceptable. And I will say that to them, but they need it written down so they can refer to it as they're studying for seeing their patient models, which is something that I've also asked students to do that I've never done in the past, is that you're seeing a patient tomorrow. You need to go home and study. You can't just remember everything that I showed you the day before. So it's a lot of writing, but I really find that it helps them. So let's briefly talk about the volunteer assessment forms. This is me in my younger days working with one of my patients who comes in as a volunteer with a hip disc articulation amputation. My patient volunteers are near me, as I'm sure all of yours are. They're wonderful people, and they put themselves out there to work with the students, which is marvelous, but I want to make sure they're well taken care of by the students, and I want them to feel like they're part of the education process. In many schools, they have the money to train people to be professional patient models. That works well in schools of medicine, but with amputation, I find you really need the pathology to be present. You can't fake it. You know, casting somebody that doesn't have an amputation only gets you so far. So I'm going to click on my volunteer assessment form here. Okay, so my volunteer assessment form is fairly simple. There's instructions, which nobody reads. That's kind of pretty well known. But we have, a space for the volunteer's name and the student and the project title. And then some pretty simple statements with space for comments. These are things, when I'm thinking about what sort of feedback do I want from the volunteers, or both, what do I want the students to learn? So I want the students to learn to be respectful while they're working with their patient models. But it's hard for me to assess that, so that's something that I've chosen to put on the volunteer assessment form. And they can just use this simple scale of strongly disagree to strongly agree, and they can write some comments if they want. The student demonstrated compassionate care, so they rate them on that. And the student made every effort to ensure my safety when asking me to walk or stand. So just common areas that I found that the volunteers do better at. This goes on. It's see, what do I have here? 9 questions. Here's a few more examples. It's split into 2 pages. I use the same form for every visit, but it's split that way. So some of the questions ask about taking a cast. Like, basically the question is, did they remember to not rip all your hair out? Or did they do it like they were supposed to? So those sorts of things are also on here, because I found that assessing students at this level can be challenging, and you need all the help you can get. I can't pay attention to everything that's going on with every single student. Now here's the trick. Let me see if I can get back to my PowerPoint. Okay. So those are some examples. If you would like to see the full forms again, just please email me, and I'll mail you back these documents. So here's some tips as you're thinking about writing these sorts of forms, or maybe rewriting the existing ones. Written comments, I find, are not sufficient to convey what the student has learned and where they need to grow when you're giving them feedback on patient models. So I schedule in my syllabus 15-minute chunks of time throughout each project, and it takes a long time. 15 minutes, you got 20 students. It kills a large portion of the day, but they find it incredibly valuable. And for some common things that I find, I end up trying to cut down my time by giving group feedback. So I don't identify anybody individually and say, you had a problem with this, why don't you stand in front of the group and tell us how bad you were? I would say, I saw a lot of people casting their patients in knee flexion. That's a problem, for this reason. And then I can skip it in my individual feedback sessions. So I find that you have to give both oral and written feedback. Again, I talked a little bit about maintaining a positive learning environment, only because I screwed that up in the beginning. I took it from, this is a wonderful thing working to patients, to, my goodness, I'm being really assessed and scrutinized. So I had to kind of flip that around and make sure that you make supportive comments, because people want to know what they're excellent at, and they don't necessarily know. And so I acknowledge their strengths, I recognize their areas for growth, and together during that 20 minutes that we spend together, I say, this is what you did really well, keep doing that. This is where you need to grow. For example, spend some time figuring out how to get your plaster accurately saturated and laying it on the residual limb so that it doesn't create rings as you're casting. The way you talk to your patient, it was incredibly respectful and really put them at ease. This is an area where you're doing well. This is an area where you need growth. So that's part of my setting individual goals. And then sometimes this assessment form, doing it a couple days later, doesn't work. That sometimes I find somebody's doing something crazy with the patient model and it needs feedback immediately. So I don't let that form guide everything that I do. I have this technique that I was taught by a great mentor who's a general surgeon actually, and he helped me with teaching. And he said, this is what I do when I'm in surgery. I say, when somebody's doing something crazy recently was, it was a wet, slippery floor, and they had a geriatric patient with a walker standing up, and they were just going to fall over and hit the floor, and I needed that person to sit down. So I walked over, and I calmly told the patient model to have a seat, and I said to the student, I really need some help getting some plaster for the rest of the people to cast it. Can you help me with that? And as soon as we're outside, that's when you say, don't you ever do that again. Because these patient models are people that you can injure. And so having those sorts of discussion in private is really important to make sure that you protect the learner's integrity. And again, I share that with you not because, I'm sure probably all of you know this, but I didn't. I made all these mistakes and calling somebody out, running across the room and saying, sit down, what are you doing? So I learned from people wiser than me that you really need to give people feedback in a private setting. Unfortunately, the students are so darn savvy now that when I ask them for help with something, they get a little nervous. They're like, do you really need help? Or are you going to give me a joke slap? Then self-assessment. Wow. Self-assessment is incredibly powerful. Students, when they fill out these self-assessment forms, they tell you exactly what they screwed up with more insight than I ever had. They know what their problems are, and it makes this process go much faster. So if they screwed up, and I think they screwed up, then we don't even need to address it. We lay the same form side by side, and I say, yeah, okay, good. You screwed up. Do you know how you're going to fix it? Yeah, they've got a plan already. Fine, we move on. It's not a problem. Before I had these forms, I used to spend all this time saying, yeah, this is an area where you need to grow. I missed the glazed over look on their eyes where they knew exactly what was going on. So I think self-assessment is really important. And then there's another real gem. I mean, we need to know, as clinicians, when our work is not adequate. It's, I think, fundamental to prosthetics and orthotics that we can assess our own work. And we make mistakes all the time. I used to have this mentor who said, you're only as good as your last leg. And, that's it. Not 10 ago. I don't care if that one worked. If this one doesn't work, you're not any good now. And so we need to be able to accurately assess whether or not our care needs revision. And so the way I teach that is by having people assess themselves. And as somebody mentioned earlier, if you think you're lower than you are, that's just as bad as thinking that you're higher than you are. You don't need to make these self-effacing comments and be humble. When you do something well, it needs to be recognized, and when you do something bad, like all of us do, it needs to be recognized also. So I think self-assessment is a key part of the equation to assessing these patient model visits, which can be really ambiguous at times to assess. And then this volunteer feedback. I just can't say enough how important it is to get that feedback from volunteers, because they see things, even though we're all in the same room with the curtains pulled, that I don't see. And usually they capture the things that the student does so well, much better than I do. So a volunteer feedback component is important. So let's wrap it up. I really feel strongly that when your students are seeing patient models, that assessment improves the learning process. If you really clearly lay out exactly what it is that they have to learn, they will do it. If it's ambiguous, they're really going to struggle. And Unfortunately, because I don't like to write. I know that's crazy for somebody who's been stuck in the middle of doing a dissertation for years, but writing is hard. And so writing down psychomotor skills, I think, is the key to telling your students what you want them to do. Development of, yeah, I said this already, didn't I? It's hard, but it's worthwhile. And taking the time to not just pass somebody a piece of paper, but provide them with oral feedback is also very valuable. Because sometimes the paper alone really doesn't convey the sentiment. It's like, we've probably all written emails that we intended to be perceived one way, but they weren't. So writing, again, is great, but not the only way. And then seek multiple sources of input. I am not the only person who assesses my students. I have volunteers who are clinicians who use the same forms. I have the students assess themselves, and I have the patient models also assess the students, as I told you. So as you go through and you think about creating assessment measures for patient model visits, think about these key points. Thank you very much.
Do we have any questions for Daniel at this time?
Yes.
I'm glad you said that the students get savvy to you assessing them, because no matter how nice you are about giving positive feedback, they know what you're assessing, and then they play the game to get better marks. I think, if possible, it's good to do one cast first, if you've got the time, where you're not assessing them, and then you say, ask as many questions as you can, and do it that way. Otherwise, you just don't get the questions when you're assessing the student.
Yeah, I struggle with that same thing. It becomes hard to figure out how to fit everything into the curriculum. So it's actually optimal to have a less formal assessment. But I think what I'm trying to say is that though a paper-based assessment that clearly lays out what you're asking the students to do can be perceived as a grade, like something they do on the test, it actually makes the learning process, if you bring the right tone, less intimidating. Because what I didn't share with you is I have a section on here where I talk about the students seeking feedback or asking questions. So if they don't ask me any questions when they have them, I give them feedback on that. So because we've all had those students who ask too many questions, and they really don't rely on their own knowledge, and then the other students who don't ask any questions. So I try to wrap that into the assessment and say, look, I'm going to give you feedback, it looks complicated, but I really need to assess you all along the way, but don't be intimidated by this. And part of shifting from a grade to competency-based helped that process where I said, good, you're checked off. Doesn't mean you can't go back in the other direction and get worse, but in general, you're doing well in this area, so we can relax.
It's interesting to hear about you talk about volunteer feedback, but how reliability of the information that you get from the volunteer? Because from my experience, all the time when we invite volunteers, more of volunteers want to help students.
Yes.
And they want to help. And
yes. Yes.
For example, if they try to grade very good,
yeah.
And then how we can encourage our volunteer to provide accurate information.
Continue with that question. I also have the same question.
I'll repeat the question. The question was, I think, to sort of summarize it, is that our volunteers tell the students that they're wonderful, and that also sometimes they're not. So, from our perspective as educators, they're not very accurate in perceiving the challenges that the students face, and how do you deal with that? Or another one that I can throw out that I was concerned about was some volunteers are great at giving feedback, and other ones are really miserable. And what I've come to find is it doesn't matter. They're just like patients. Some are really good at giving you feedback, and some are really miserable. And that's just a normal part of the process, and they all rotate through different patient models. And so it gives us talking points that when we sit down, we can say, oh, good, this is how you're perceived. What do you think about that? And the students are so insightful. When you ask those questions, you find they say, oh, well, Jane, Jane thinks everybody's wonderful, so I don't really place a lot of weight in that. But now Bill, he just thinks everybody's awful, so I don't place a lot of weight in that. So they are savvy to that, just as I am, and I don't use that portion as one of the competencies, but it gives us a conversation point. Thanks for asking that. Okay, thank you very much.